The speaker is Dr. Avinash Deo. He's a consultant medical oncologist at SL Raheja Hospital, Holy Family Hospital, and Nanavati Hospital in Mumbai. Avinash did his MBBS and MD Internal Medicine from KEM Hospital and DM Medical Oncology from Tata Memorial Hospital, Mumbai. He treats both hematological and non-hematological malignancies and develops content for oncology education. He also runs a blog on hematology. Avinash is trained in medical informatics and has completed 4 certifications with Johns Hopkins University. He's passionate about applying technology for healthcare delivery and writes a blog about it too. He's a visiting faculty at 2 medical colleges in Mumbai and was the section editor for Oncology API textbook 8th edition and has authored some chapters. He's a member of the editorial board of the Journal of Association of Physicians of India and was involved in the report generated of First Cancer Care. Thank you, Avinash, for agreeing to do this talk, and thank you, Ravi Shankar, for coordinating. Moderating the session will be Dr. Amita Trehan. She's the professor and in charge of Pediatric Hematology Oncology Unit at PGI Chandigarh. She did her MBBS from CMC Ludhiana, MD Pediatrics from PGI Chandigarh, and fellowship in Pediatric Oncology in UK. Her areas of interest are ALL, AML, hepatoblastoma, Wilms tumor, thalassemia, and supportive care in oncology. She has 74 national publications and 115 international publications. She's authored 12 book chapters and is the section editor of Thrombosis and Hemostasis in the Pediatric Hematology Oncology Journal. Dr. Amita Trehan is on the executive committee in pediatric oncology in Eastern and Mediterranean countries and is on the advisory board of Asian Pediatric Hematology Oncology Group. She's also an advisor on the National Health Mission of the Punjab government and is the chairperson of Pediatric Hematology Oncology chapter. Thank you, Dr. Amita, for sparing your time and joining today's session. Over to you, Avinash.
Thanks a lot for Vidya for inviting me for this session. I think I'll start sharing my screen. I think maybe a few years ago, if we had talked about immunotherapy in cancer, this was more like a dream, you know. I remember the first so-called immunotherapy I used in cancer was a drug called levamisole and was used with 5-fluorouracil for colon cancer. We've come a very long way from there. And I think, particularly in the last 5 to 7 years, there's so many indications which have come up for, first for adult oncology and now I understand for pediatric oncology. They're making a very great impact in many of these diseases which were otherwise unresponsive to tumors. The changes in terms of the class of drugs available, the way indications are expanding has been remarkable really. Over the last 3 to 4 years, we've had so many indications coming up, and there's a difference. I mean, there are treatments which come and go, but this is something that will stay. The responses are durable. There are some people respond very well, but they respond very well, and believe that it changes the outcome at least in maybe 15-20% of patients. But that's how oncology is. I mean, each treatment affects a section of cancers. They do better. Then you discover a new way to treat, and so on and so forth.
Avinash, if I could interrupt, could you just speak closer to the mic or a little louder? Yeah.
So I think 1 second. Yeah. Okay. Now, as we know that cancer really has treatments really evolved maybe over the last 100 years. There also till Halsted described radical mastectomy, nothing was available, nothing was believed to be effective. Radical mastectomy was believed to be effective, but again, we don't know whether it was. Then came radiation, then the Second World War, then came chemotherapy. By 1990s, we had something called targeted treatment. And then 2010s around approximately, we have immunotherapy. If you see the CML survival by years, somebody's charted, it came from 8% to 92%. Today, we don't transplant for CML. We don't use chemotherapy. And most patients will be on drug treatment for years. Like, yes, you say you will be for hypertension or something. there are some tumors which would not respond. You know. 1 second. Yeah. Now, in August 2015, Jimmy Carter was diagnosed with melanoma of liver and brain. Now, melanoma has been a tumor which has not responded to all forms of conventional treatment. The first treatment, which is probably effective somewhere here, which is interleukin. And now what you find is, maybe now it's about 7 years with metastatic melanoma. At the age of 97, he's still alive. And the beauty is a drug called pembrolizumab, and this is the beauty of immunotherapy. So many drugs, so many tumors which we could not treat otherwise are curable now. Before we understand this, I think we should try to see I mean, there's a concept of hallmarks again. What is cancer actually? What are the features of a cancer cell? So in 2000, Hanan and Weinberg, they published an article in a journal called Cell, and they listed 6 features of what they thought were the kind of defining features of cancer. It was sustained proliferative signaling, evading growth suppressors, enabling replicative immortality, activating invasion and metastasis, inducing angiogenesis, and resisting cell death. They visited these again after 10 years and added 2 more. And what they added was avoiding immune response and dysregulating cellular epigenetics. So a lot of tumors do avoid immune response. Tumors are immunogenic, and as we understood how to use this, how to manipulate this, a lot of immunotherapy is evolved. Just to, I'm sure everybody knows this, but just to summarize the components of the immune system, you have the barriers, you have the soluble components, and you have cellular components. And we know the cells: granulocytes, monocytes, dendritic cells, NK cells, and so on and so forth. In cancer, we target the dendritic cells and T lymphocytes. See, cancer is a disease where you need to have T cell immunity, because humoral immunity is not really effective against cancer. Cancer kills are by cellular kills, either by NK kills or they can be T cell kills. So we are manipulating dendritic cells and T lymphocytes, and this is what the talk is all about. Mainly T lymphocyte. Dendritic cells are used in 1 or 2 indications, and there are some other early studies that you can use you can stimulate natural killer cells, but this really not come to the clinic. If you see the cells of the immune system, there are they can be classified in two types. One is the innate immunity, which is fast, weak, not specific, but has no memory. But it's fast. I mean, it doesn't require recognition of a particular antigen. Like natural killer cells recognize a malignant cell. They recognize an infected cell. They don't have to recognize. They don't have to know what kind of infection. Whereas adaptive immunity is slow, strong, specific, and has a memory. And what we are talking about is T cells today. Today's talk is mostly about T cells, how to stimulate T cells to kill the tumor cells, and that's what cancer immunology is all about today. Now, is cancer immunogenic? Yes, cancer is immunogenic, and there have been many observations, through history. There were multiple observations that tumors regress with infection. With this happens usually with high fever. In 1891, William Coley noticed spontaneous regressions after erysipelas, and he made something called a Coley's toxin, Streptococcus pyogenes and Serratia marcescens. They were initially live, and then they killed it. And with this thing, he could get some regressions, but he could never replicate these things. I mean, there's no consistency in regressions. When there have been instances where melanoma has regressed after autoimmune disease, and either iatrogenic or disease-related immunosuppression has been shown to increase the risk of cancers. These cancers are usually viral-related, EBV and HPV, and they regress once immune restoration occurs, where you can do, for example, when you reduce the immunosuppression, some cancers do regress. So there's a role for immunity in cancer, and actually, it's surprising that the first effective drug, so-called, for cancer was actually immunotherapy. But then what happened is that there was a serendipitous discovery of nitrogen mustards, and then the immune system is very complex and still very complex. And at a time when we did not have molecular biology, I think to understand immune system was very difficult. So somewhere immune system got, people realized they could not manipulate it. It got left behind. Okay. What is important to understand is the T cell lymphocyte activation and disruption in cancer. So as we all know that T cells recognize antigens on cells. You react to a graft, but not your own cells, because early in development, your own antigens are recognized as self, and you develop a tolerance to it. But what happens in cancers? Cancers are basically genetically unstable, and they have the ability to tolerate and propagate mutations. I mean, if a normal cell gets mutations, there are systems to actually control it, either by killing it or by not allowing it to divide. But cancer overcomes all these things. So intrinsically unstable, and because of that, it generates new antigens. And these new antigens, your tumor's T cells can react to. But at the same time, the cells also generate certain systems which suppress the tumor. The host becomes tolerant to these cells. The T lymphocytes don't react to the antigens because of the systems. And if you see that a class of drugs called checkpoint inhibitors, which I'll discuss later, are all about reversing this tolerance. Also, if you see that immunotherapy is more effective in tumors which have a higher mutation, for example, those who are in something like Lynch syndrome, which have a microsatellite instability where they tend to mutate more and more, or tobacco-related cancer. In fact, almost all tobacco-related cancer have some role for immunotherapy, starting with head, neck, lung, kidney, bladder, and melanomas, again, exposed to sun, a lot of very high mutation. So where there mutation rate, the cancers are more effective. I mean, the immunotherapy is more effective. Something more T cell, and then it requires second signal called co-stimulatory signal. Now, this co-stimulatory signal normally is CD28 with B7-1 or B7-2, but there are also antagonistic influences like CTLA4 and PD1 and TIM3, and there are many more. I mean, I'm listing this because these two are used therapeutically. When there is co-stimulation, there will be immunity. When there's absence of co-stimulation, there will be tolerance. And what your antigen present in cell essentially does, it gives you the digested antigen on MSC2 and the co-stimulus. The cancer immunotherapies, I mean, you can, if you want to sort of classify them, there are certain things which are kind of who would restore immune responsiveness, and there are other things that we actually are trying to stimulate the immunity to generate the T cells which can act against cancer. We are most successful in the first one. The second one, we are not all that successful because the process is more complex. If you see the ongoing trials, I mean, I picked it up from clinicaltrial.gov. The commonest, the most frequent number of trials are for checkpoint inhibitors. Then you have cancer vaccines, and then there are other things like CAR T, interleukin, oncolytic virus, and bispecific T cell engager antibodies. But what is important is there are about close to about 500 trials which are in phase 3. And oncology trials typically have a 35% approval rate from phase 3. So even if you have a very conservative estimate, we are expecting about 50 new treatments to develop over the next few years. And this is a very large number, Okay, the first immunotherapy which was used was interleukin-1, very non-specific. It's a T cell growth factor, approved way back in 1992, and for renal cell carcinoma, then 1998 for melanoma. The high-dose interleukin-2 was a difficult treatment to take. The response rates are modest, higher toxicity. You get capillary leak syndrome. They're required to be in ICU. You need to select patients. People with cardiac and pulmonary disease are not able to withstand the treatment, and you require special training, special centers, require ICU. So this really never caught on. I mean, though it was kind of a demonstrative this thing, but if you did not have these things, interleukin-2 did not really make an impact. What changed everything is checkpoint inhibitors. And if you see again, we are having almost 2,500 trials ongoing and 231 phase 1 trials. There are at least 50 to 60 trials on which are phase 3 trial, which are chain practice and which have been published in the last few years. And every time a new indication is added, there is something which is happening every few months, I would say. Now, what are checkpoint inhibitors? The immune checkpoints are inhibitory and stimulatory pathways, and they maintain the balance between pro and anti-inflammatory signaling. Malignant cells disrupt these pathways by promoting an immunosuppressed state, in the sense of the body becomes tolerant to a newer antigen, which is not learned to be tolerant. And immune checkpoint inhibitors block these negative influences, make the body react again to the malignant cell and restore the immunity. We are talking about PD-L1 and CTLA-4. Actually, the order of, the first antibody available was CTLA-4 antibody, but somehow ipilimumab, which is CTLA-4 antibody, has not been that effective. But PD-L1 antibodies have been very effective. PD-L1 and PD-1 and PD-L1, they have been very effective. These are the two main antibodies available, and this is what we'll be talking about most of the, the subsequent slides. PD-L1 and CTLA-4, they are the checkpoints which have been exploited therapeutically. They interfere with the second signal. It's all about that they interfere second signal. They don't allow the immunity to develop. And they are expected on activation. And you have knockout mice and you have human deficiency, which actually replicate autoimmunity, which can be seen with the checkpoint inhibitors. And the CTLA profile of disease as well as knockout mice and CTLA profile of PD-L1 as a knockout mice is different. And it replicates again the kind of toxicity you see in patients. CTLA-4 is mainly regulatory in early lymphoid tissue and plays a critical role in central immunity. And PD-L1 is in late immune response and plays a role in maintaining tolerance. For some reason, which is unclear, PD-1 targeting is more effective. It's possibly that the more tumors use PD-L1 as an escape mechanism. It may be as simple as that and nothing else. PD-L1 are also probably less toxic and easier to handle. Okay, there are three categories of checkpoint inhibitors. One is CTLA-4 inhibitors, which is ipilimumab. Then there are PD-1 inhibitors, nivolumab, pembrolizumab, and cemiplimab. And there are PD-L1 inhibitors. PD-L1 is ligand which binds PD-1, atezolizumab, avelumab, and durvalumab. So there are about 7 or 8 antibodies we have, which we use in different ways. As you see in the next slide about indications, pembrolizumab has been there in the longest, and most of the indications, are for which we use pembrolizumab. But you will realize that once the first drug is introduced, any other company which wants to come in, pharma company, has to do something different, And then you find that there are pockets where the newer, the other PD-L1 inhibitors and their later antibodies are being used. If you see, the most important indication for our country is lung cancer. Maybe worldwide it's melanoma, but because we don't have melanoma, which is so common, lung cancer becomes the most important indicator in our country. Then we have kidney cancer. Head neck cancer is important, but it's a disease of poor people. These drugs are patented, and it becomes an issue using these drugs in head neck cancer. Again, though responses are there, prolongation is there, but practically speaking, I think many people don't go on to the drug. Hodgkin's is a very odd indication. It's post-transplant. So again, to get a relapse in Hodgkin's, which is otherwise also very curable, and to go to transplant, but very responsive in that indication. Then there are things like MSI, microsatellite unstable colorectal cancer, gastric or gastroesophageal junction cancer, mesothelioma, again urothelial cancer. The list goes on like this. Hepatocellular cancer. Then certain tumors like Merkel cell tumor, basal cell tumor, these are uncommon tumors. Endometrial carcinoma, which is MSI high, and triple negatives come to. And there's something on tissue agnostic. That means one of the few drugs which is used irrespective of histology. That I'll come to that in a later slide. Just to go through the process of how to select immunotherapy in cases of lung cancer, which is the commonest indication, and which probably captures all what we do in all the choices we need to make before we start immunotherapy. Lung cancer, as we know, can be small cell or non-small cell. Small cell carcinoma traditionally was treated with chemotherapy, but atezolizumab plus is added to chemotherapy, and that is increasing the control rates. Non-small cell, what we need to understand is that there are certain tumors which will be responsive to what we call targeted treatment, which will have driver mutations. If that is not the case, then you check it for something called PDL1, and depending on the PDL1, you decide whether you will use chemotherapy or single agent. Now, all patients don't respond to immunotherapy. You need some markers. PDL1 is the marker which is there. There are many other proposals, but for all practical purposes, PDL1 is the only one which is used. And PDL1 is slightly complex marker, which I'll again discuss in next few slides. It's used sometimes, it's not used sometimes. So it's not a perfect marker, but that's what we have in lung cancer. So each tumor, what is important to emphasize is that even given the same histology, the same subhistology, you will have different biologies of tumors. And what we do need to know is that we need to choose out those tumors which are likely to respond to immunotherapy to save the people who are not likely to respond of toxicity and the cost which is incurred. These all drugs are patented. The earliest patent goes out is 2026 for nivolumab and 2028 for pembrolizumab. So till that time, the cost will be an issue, at least in our setting. Okay, then we're talking about tissue agnostic. If you have microsatellite instability, microsatellites are small repeats of DNA sequencing we find all over your genome. And instability in this microsatellites indicates that there's a mismatch repair defect. And patients who have mismatch repair defect, which are known as Lynch syndrome or hereditary non-polyposis colorectal cancer, these people tend to generate more mutations. When you generate more mutations, you generate a more antigenic tumor. And in case the tumor has escaped immune kill, it is done so by developing tolerance to PDL1 or CTL, PDL1 mainly. So if you have an immune checkpoint inhibitor in a MSI high disease, you will find that it will work across histologies. This is unique because all drugs which we have used up till now have some kind of relation histology. And this is one indication which is on very small number of patients. Actually, very honestly, I'll tell you, the numbers are less than 200 in trials, but it's a very unique indication and it is effective. Something about PDL1 testing, if you're going to use a checkpoint inhibitor, in some circumstances, you require PDL1. Usually first line requires PDL1. In other circumstances, you don't require PDL1. For example, if you're going to use a drug called nivolumab in second line, you don't require second line lung cancer. You don't require PDL1. But if you're going to use pembrolizumab first line, then you require PDL1 because it decides whether you're going to add chemotherapy or not. But the problem with PDL1 is that there are multiplicity testing methods. It's done by immunohistochemistry. Immunohistochemistry requires a monoclonal antibody. Unfortunately, as trials have started, each monoclonal antibody to treat has got its own companion monoclonal antibody to test. And also there are different platforms and all that. So I need to know. Today I got a call saying that you send a sample for head and neck testing. What antibody are you going to use? Now, this is something which a pathologist will never ask you, but he has to ask you because if you're going to use pembrolizumab, there's one clone to be used. If you're going to use nivolumab, a different clone to be used. So these are complexities of testing. And despite that, you find that PDL1 is used as a marker in many places. In lung, you have a 50 cutoff. In most of the tumors, you have more than 1%. In some indications like small non-small lung cancer relapse, you use it irrespective of PDL1. So and PDL1 negative tumors do respond to it. We ask for PDL1. It's important deciding, but it's not a perfect kind of a marker. That's what I'm saying. There's something called tumor mutation burden. Again, lot was written about it, but somehow it's not come out to a threshold where we will be using it clinically. I think this is what I was saying, that when you have a monoclonal antibody to use, you have to ask for the accompanying IHC, and the pathology institute told what you are likely to use. What studies try to harmonize these studies? I mean, I would like to have as a clinician, I would say, okay, this is a test I want. I would not want to say I want to use this antibody in this test. I mean, it's a different way of practicing. We are not used to it. So that's not happened, unfortunately. Harmonization of studies has not happened, actually. So just to illustrate what I was saying, if you're going to use a nivolumab, you'll use a monoclonal antibody called 28-8. If you're going to use pembrolizumab, you're going to use a monoclonal antibody called 22C3 and a platform which is of a specific company. Then for atezolizumab, you'll use something called SP142 on a Ventana platform. And for durvalumab, you'll use something called SP263. So this is slightly complex thing, which which is different from others. Then there's a reporting score. You have something like tumor cell score. You have something like tumor proportion score. You have immune cell score, and you have CPS score. And again, trials are going to use different scores. So you have to be careful what you're using. Toxicity kind of replicates, it's a non-specific enhancement of T cell reactivity. And histologically, you have depletion of naive T cells and you have accumulation of activated T cells in peripheral tissue. It manifests as hypothyroidism, hepatotoxicity, basically end organ tissue damage. Something like happens in an immune disorder, something like autoimmune generalized disorder like SLE, maybe something like that. But the profile of toxicity is very different. The profile of toxicity can be predicted by human disease knockout mice. If you see the knockout mice, probably it has some relationship with the kind of toxicity. And there have been modifications in the way you give antibodies or the way you process antibodies to try to reduce toxicity, but it's not perfect and it's not come up to clinical use. The targets, my prime targets are dermatology, gastrointestinal tract, hepatic, and endocrine, and many others. Now, for example, if you are looking at, and lung, of course, lung I have not mentioned. Now, if you're looking at lung toxicity, endocrine toxicity, you're looking at different things. Because if there's endocrine toxicity, suppose a hypothyroidism, you will go ahead and you will not reduce treatment. You'll continue to do that because you can supplement. But suppose there's an pneumonitis, you'll have to change treatment, reduce treatment, or you need to, or diarrhea, or for that skin rash. It will require intervention. Some toxicity may be fatal, so it's important to recognize it. It's important to intervene in time. What do you do for intervention? It may be discontinuation, which is temporary or permanent. Then there'll be immunosuppressions used in the form of glucocorticoids, TNF-alpha agonists, or mycophenolate. These are based on common sense, case reports, small series. There are no clinical trials. When you use immunosuppression, you are offsetting the advantage of checkpoint inhibitors. The next question comes: if it induces autoimmunity, can we use them? Again, it seems you can use them, but you have to be careful. I have two patients, one on psoriasis, one on rheumatoid arthritis. Rheumatoid arthritis patient had a kind of flare-up. We put 5 mg of prednisone, and then brought it down to 2.5 mg alternate day. The autoimmunity settled down. He's an 85-year-old man who will not go for any other treatment, and he's responding, and it's almost 1.5 years now. So yes, you can use an autoimmune disorder, but again, no trials. It's only a compilation of patients. And as in oncology, you have to see what the options are. I mean, if you have some better option, probably you'll not use. Can we predict toxicity? Answer is no. A lot of parameters have been tested, but nothing seems to be able to use to be good enough for us to use in clinical practice. So you have to keep a clinical watch and monitor these patients. Right now, up now I talked about single agent, but it can be used as combinations. The nivolumab and ipilimumab combinations are used in many indications where you want to avoid chemotherapy. You can use what we call IO plus IO combination. It is more toxic, definitely, And these drugs being very effective, very few people have a large experience in our country at least. But that option is there. You can give IO plus IO, what we call, in patients who are not fit for chemotherapy. Then there's a large number of patients indications by using checkpoint inhibitors plus chemotherapy. I mean, lung, colon, G junction. Then there are something tyrosine kinase inhibitors. Usually these are VEGF inhibitors, exitinib, lenvatinib, cabozantinib. Again, there are studies and there are first-line treatments where you use both. And there's a drug called bevacizumab. So, we're using this in many other ways. Checkpoint. If you want to increase the immunity, like for example, some vaccines and all that, again, these checkpoint inhibitors have been used in experimental setting. But what I've listed are actually clinically used indications which are in use today. There are other checkpoints. Again, this experimental work, trials which are being conducted, and maybe something will come out of it. Let's see with time. But none of these are as of today in clinical use. Then there's a large role for manipulating T cells, but they're difficult to do. And what has happened is that if you see the number of treatments available in this category of this are very few, probably 3 or 4, not more than that, if I'm not mistaken. There are benefits. I mean, T cells are specific. They can differentiate between healthy cells and cancer cells. The responses are robust, and you can expand those cells about up to 1,000 times. They can go anywhere, and immunity is long lasting. It stays. So you can, once you infuse, maybe even those what we call maintenance treatment cancer theoretically can be taken care of. The first attempt was to collect T cells from biopsies to expand them using interleukin-2 and reinfuse them. There were some response rates, 4 months response, objective response to 35%, but these are not really something which caught on, Then there were attempts to bioengineer T cell receptor, same problem. I mean, it really did not make an impact. What made an impact was 2 things. Chimeric receptor, antigen receptor T cells, and bispecific T cell engagers. Both these treatments, what they do is they get you the T cell next to the they are able to bypass the need for activating T cell actually. Normally what happens is that a normal antigen has to present it on a dendritic cell, activate T cell, and then the cytolysis occurs. Now, many cancer cells don't express MSC very well, so they are not very immunogenic. So CAR T and bispecific T, they are able to bypass this. Again, the idea is that there's an antigen binding domain and there's a signaling domain. So antigen binding domain binds to the the antigen binding domain binds to the cell, and this and T cell signaling is initiated by this. It's able to directly kill these cells. It can have severe toxicity like multi-organ failure, coagulopathy, capillary leaks, and tocilizumab has been used for that. There can be confusion. You can have delirium. You can have seizures. These cells are manufactured actually. So these are the T cells which are under evaluation. It's not really come to frontline therapy, but CAR T cells are used in centers which have experience. So not many people are doing that. It's a sophisticated technology. Then you have the bispecific T cell engagers. What these do is that they bring together the antibody has a dual specificity. It brings together tumor cell to a T cell. The T cell releases cytokine and kills the T lymphocyte, the tumor cell. Blinatumomab is an approved drug for adults and children ALL. It's used as a bridge to transplant. There are many other indications. I mean, these are the list of drugs. The first one is CD19 used in leukemia. The last 4 are used in lymphoma. They are CD20 plus. As you see, other last 4 are all in development stage. They are used in later lines. They are for development. And I think with time we'll hear more of these drugs coming into clinical practice. There are oncolytic viruses which are used. Only one virus And I think they are basically infect the cells and they cause some kind of lysis. This is two things about this. One is this biologicals are having more and more difficult name to pronounce, tongue twisters, and this technology again is being evolved. We use it for intramelanoma injection. I mean, other things are really not available today. Then you have cancer vaccines. It's a very exciting idea, and again, if you can engineer vaccines to actually therapeutic vaccine. We're not talking prophylactic. There are two vaccines. There are prophylactic vaccines: hepatitis B vaccine and human papilloma virus vaccine, which is for hepatomas and for cervical cancer. But we're not talking about. We're talking vaccines which can actually enhance the immunity and we can get a tumor kill. So the problem is that the tumor antigen may not have immunogenicity. You need to vaccines which can elicit T cell immunity and can stimulate cytotoxic cells. There are 4 platforms available: cell-based, virus-based, peptide-based, nucleic acid-based. I think the only vaccine which come to clinical practice is a vaccine for prostate cancer, Cepulicel T. BCG was used traditionally before we understood what it was, and it was used for superficial bladder tumors, still used. Other than these 2 vaccines, it's really not come into clinical practice. But you see the amount of work which is going on. These are trials across the world. Again, almost 2,500 trials, but only 4 approved vaccines. It's a difficult job because to induce immunity in tumors which are trying to evade immunity is not very easy. You can have new antigens, but new antigens tend to be tumor specific. So are you going to develop vaccine for each person of a group of persons? Are you going to have a set of say 30 or 40 common antigens, new antigens, and do it? So there are many issues here. Okay, and I think all these things need sorted out. There are trials. Only one vaccines come to usage as it. I mean, I think the science behind this is probably more difficult than PDL1. Just to give you an idea what this prostate cancer vaccine does, you expose you collect the leukocytes, separate the mononuclear cells, you expose it to a fusion product of prostatic acid phosphatase and GM-CSF, which is adjuvant, and reinfuse it. So you expect that these prime cells will present the PAP to the T cells and induce a prostate cancer kill. The median survival is 25.8 months versus 21 months, and it's got some role in prostate cancer, maybe low volume disease. But again, they're all in that also checkpoint inhibitor come, and maybe I don't know how it will go actually, very honestly. Then there's a set of cells which are other than T cells which are used, and out of that, the closest to being used clinically are NK cells. And you have CAR T, you have NK directed cells, you have allogeneic NK transplants, and all these things are there. Some have been approved for, some have been shown to be safe, some have been shown to be effective, but these are phase 1, phase 2 trials, none in advanced trials. So our cancer immunotherapy will be restricted for some time at least to dealing with T cells. I think to summarize what we are looking at is, despite being immunogenic, cancers elevates immunity. We know that now. Immunotherapy with PD-1, PD-L1 inhibitors is the most effective form of cancer treatment, immunotherapy today. Many of them are able to take care of cancer traditionally poor responders to chemotherapy. The prime examples is melanoma and renal cell carcinoma. These don't respond to chemotherapy. Like CAR T and bispecific T cell engagers are under development. They are in use also, but they are not come as a mainstream. And again, these are few centers and cost is an issue. And newer targets are under evaluation. I think this is a very exciting area, and I'm sure we'll hear more and more of it, because we really I don't know if you know that there's no chemotherapy drug which is patented. Last 20 years we have not had a single chemotherapy drug, so we're out of that now. We're just trying to get something better than that. But there also, I think we're not adding much value. We are adding value in targeted treatment, personalized medicine, and immunotherapy. I think immunotherapy has made the biggest impact in last 4 to 5 years, and we have got responses. We have seen patients who otherwise would not do well responding and actually having meaningful survival. And some of them will go on for a long time, and they'll do so without even when the therapy is withdrawn. So I think this is an exciting area, and I think with this I will I'll end my talk. Any discussion, any questions we can address?
Thank you, Avinash, for addressing a complicated topic to a non-specialized audience. I'm sure it would have been easier to talk to fellow oncologists, but to talk to people across the spectrum is difficult, and you try to make it as simple as possible. Over to you, Amita, for your comments and questions.
I didn't touch pediatrics because I don't practice pediatrics. Amita can help you with that. Okay.
Can you just stop sharing your screen?
Yeah.
I'm sorry.
Thank you so much. That was very interesting because it's we are moving towards this era now. You know, I think targeted therapy started after imatinib came into the picture, and now we've gone on and on and on. And I think what Dr. Deo has said is very correct. That till about a few years ago, this was just on paper. And now gradually, I think all of us have had the opportunity to use one or the other of these new, either a monoclonal antibody or a checkpoint inhibitor, the two ones. Obviously, vaccines, etc., are too far away. And I mean, I'm sure people who are in oncology have seen results. So it is extremely exciting. Right now, I think the biggest issue is the cost. Like even in pediatrics, we've used monoclonal antibodies a couple of times and it's prohibitive at the moment. But then, while he was talking, I was just thinking back and remembering that when the imatinib tyrosine kinase inhibitors hit the market about, I think, 15 odd years ago, the only thing available was the Gleevec, which was the original one. And then it was sponsored by the pharma company itself to patients. And now it is so easily available, because of generics. So I'm sure the same thing will happen to what you are saying. And soon it will be available to all, and obviously that will translate to cure for all. A little bit of trivia when you were talking, William Cooley, you said the father of immunotherapy was actually a bone surgeon. So you can just add on to trivia of that. And let me just check if there are any questions. Not yet.
Would you like to talk about pediatric experience of immunotherapy?
Yeah. So in pediatrics right now, it's mainly in leukemia, in which we've been using monoclonal antibodies. Dr. Deo referred to them, blinatumomab, and the other one, inotuzumab, which has been used probably across the country by a few people. In all honesty, we've used it in about 4 children till date, last couple of years when it's been available, because the drugs have to be imported. And even quite a lot of the adult drugs have to be imported. Nothing is available in-house. And the cost is, in a child, in a 10, 11-year-old child, it has cost us a good 40, 50 lakhs, just to give people an estimate, which is not easily, it's very difficult. And so far that's what restricts it. So, when we used it in leukemias, children in any case have a much better outcome as compared to adults. And fortunately, all our children achieved remission after getting the monoclonal antibodies and went in for transplant, which at the moment all of them have had successfully, except one is possibly relapsing. But after giving the monoclonals, they all went into remission. Yes, there are side effects, which was mainly the cytokine release syndrome, which was handled. I think because we were aware of it, we already knew that we are kind of expecting it. One child needed to go to ICU for maybe 48 hours, but they managed okay. And CAR T cells at the moment in India, there is a phase 1 trial going on at Tata Memorial, which was supposed to have finished sometime in March, April. they were going to do 6 patients, not necessarily only children, for CAR-T just to establish the safety. And then they're hoping to start the next phase by the end of the year. So I guess maybe CAR-T will also become available. Of course, they're tough therapies. They are, but I think everything is tough in the beginning. If we are sitting, probably if we have this a meeting like this in 2030, we'll raise our hands and say, yes, we've used so much and the outcome is good. I know the adults in our hospital use a reasonable amount of inhibitors, checkpoint inhibitors, etc. But obviously, I'm not in a position to say that. Dr. Deo already alluded to them. So I think this is just what all in pediatrics. So I don't know if anybody else is an oncologist or anyone else would like to add on.
So Ravi, it was your idea to put this meeting together. What are your thoughts on how it went?
Yeah, sorry, I'm having some technical difficulties. No, I think Avinash did a fantastic job summarizing, as you mentioned, a very difficult topic for non-oncologists. It looks like immunotherapy seems to be the way to go for many such diseases, and people are living longer and longer with these diseases. They're no longer death sentences. And so I think the wave of immunotherapy is the reason for that. And people love their oncologists now. I think they're ready to take them home and build a temple for them. So there's things are going so well, and so I just thought that this is something that I wanted to hear an Indian perspective, and I think that was very beautifully covered both by Avinash and Amita about how things are in India and the cost angle to these things. They're not exactly cheap. So hoping that these things become more widely available, a lot more people get to benefit from them, and maybe there'll be a time when cancer is no longer the dreaded diagnosis, and Indian movies will move away from cancer when they want to kill a character. So hopefully. Yeah.
So Dr. Rajagopal, you've been in practice and you've seen probably from the days when surgery was the only option, and then adjuvant chemotherapy, and then neoadjuvant chemotherapy, and now immunotherapy. So as a surgeon, what would be your perspective about this talk?
Firstly, sir, Dr. Avinash, sir, wonderfully talk, sir, made very simple. And, it's very difficult for a surgeon to understand the very basics of this. Maybe anesthetists will understand it better because they're experts in physiology and other things. In spite of that, sir, microbiological angle, all those natural killer cells, everything, innate immunity, everything you have done it so nicely, sir. I think the recording should be available. Firstly, very good talk, sir. That is one. Second, adding on to what Madam Dr. Vidya has mentioned, when I was a PG student, mastitis carcinomatosa, I don't think they have lived, this is in early 83, 86 period. They haven't lived beyond 6 months, sir. This is a very honest thing, especially where I was. So today they are living quite a long period of time or survival, as has been mentioned. So that means there's a excellent developments in the oncological field. Adding on to this, I know a very senior professor of surgery who presented only with the extensive pulmonary metastasis, and diagnosis was later found to have carcinoma cecum. This is a very interesting thing. And with the immunotherapy, and with later he undergoes hemicolectomy, and I think we only have to say and thank God and say pray that people are living longer. Sir, my 1 or 2 question is interleukin, sir. Have you got a personal experience of using? Number 1, because I'm working I'm a professor of surgery, so we have to teach the students about melanoma, especially coming to melanoma. That MAGE, melanoma antigen gene, adoptive cell transfer therapy, and some few other things like biochemotherapy, inclusion of dacarbazine, cisplatin, and granulocyte colony factors. Are they being used in real practice in India? These are only sincere questions. That's all.
See, practice-wise, internationally, melanoma is all the way immunotherapy now, adjuvant, metastatic. But that's not practical with us, because the problem with immunotherapy is that whatever you spend, it incurs every 3 weeks or every 2 weeks, depending on what it is. And the sum is something like a 6-figure sum usually. What you do, the one in an adult, it will go to 1.5 lakh or 1.2, 1.3 lakhs. And even with the company giving support, most companies give 1-to-1 support for approved indications. So that's the problem. Interleukin-2, I don't have personal experience, because the kind of doses you have to give, it requires, it causes a capillary leak. Then the setup has to be tuned to it. And at the end of the day, when we use all that, what are the benefits? Not very many. Practically speaking, in our country, melanomas land up going for some sort of chemotherapy for whatever benefit is there, so whatever time is benefits. Very few are able to actually, and immunotherapy is not a course. It's not like six cycles and end. You go on till response, or maybe 24 weeks or some months or something like that kind. So the expenses are quite a lot, and that's what's coming. That's why I said 2026 is probably the first time we'll see some hope, because that's the time nivolumab goes out off patent. That's 4 years, and pembrolizumab, which has got more indications, goes off patent 2028. So till that time, I think, despite the help of companies, I think melanoma will be, chemotherapy will be the mainstay for most Indians. Luckily, it's not a common disease. In India,
thank you.
Dr. Amita, I interrupted you. You were about to say something.
No, it's okay. Dr. Avinash just sort of said it. That's okay. Yeah.
So Radhakrishna, your thoughts. You look very deep in thought.
Because we have this weekly MDTs where we listen to all these with awe. I think definitely exciting times in the field of oncology, medical oncology, I should say. But I don't know how much I can agree with you, Vidya, that patients have started falling in love with oncologists. Whether that is happening, I do not know. And having said that, it's quite an interesting area, because I often see in our tumor board, our oncologists putting up PET CTs of lung cancers. The entire lung is started with tumors, and then they'll give some immunotherapy, and then you see that it's becoming less and less. And a year later, it's further less. I never knew that such magic can happen. It's interesting. And having said that, we have patients, when we see as a surgeon, I see whether this is resectable, unresectable, or borderline resectable. But I think these days for oncologists, no patient is untreatable. I mean, that's what I see. So that's why I keep telling people. Actually, this come to a stage where a lot of patients with advanced malignancies ask us, sir, is there a medical treatment for it? I don't want surgery. I don't know how Avinash will respond to that. But again, the thing that intrigues me with immunotherapy is the nomenclature. How are they named like that? Because I tried understanding a couple of them, but then there's so many of them. Are these drugs named after some grandchildren or some place, or I don't know what exactly is the way this, because so many of them sound similar but different. And as you rightly agree, some of the newer ones have got very strange names. And finally, I just also want to say, of course, the expenditure is a humongous expenditure. I don't know how do you really choose patients depending upon their ability to spend money. And I also seen that the complications or the side effects are tremendous in a good number of these immune agents. I want to know whether the longevity of life and the quality of life, these two go hand in hand when you use immunotherapy.
Okay, see, immunotherapy is, there are some people who have side effects, but some will go through without any side effects and they'll be perfectly controlled. After stopping, the disease will disappear. I mean, it will not come back. That's the beauty. The figure comes to anywhere, if you see a trial now, anywhere between 10 and 15% long term. The curve seems to flatten depending on disease between 10 and 20%. So that's where we are. For example, the lung trial, pembrolizumab is given to 24 months. But there are people who control many months after that. This comes to somewhere at between 10 and 15%. That's the figure for oncology. I mean, any new treatment is probably in that range. You know, there are side effects. You have to discontinue, but those who tolerate, there are people who tolerate very well and they do very well. And the whole idea is to see that if you are dealing with a person responding well and able to continue treatment, both. Because more than toxicity, the financially it's very difficult. You know, it's very difficult to stop an effective treatment for every psychologically. If you're responding for 6 months and 7th month you run out of money, there's a problem.
See, how do you deal with this situation? I'm a surgeon. Then I say a Whipple's procedure will cost a certain amount of money. They say, sir, in another hospital, they said, you know, not so much is less. You know, for an operative procedure, which has got a limit. No, we don't operate again and again. But when it comes to immunotherapy, it's a prolonged, long-standing. Do you give an estimate? Do you give a time frame, or you know what? Sometimes
you can give a time frame. That, like I said, lung. But the time frame is 24 months. It's a long period. Usually it's till they respond, and I don't know whether everybody. There's so many people who just no longer respond after a couple of months. Okay. But you know how people are, what human nature is. Despite telling that, despite explaining everything, people will. There are some people off for it, and it becomes tricky. And you know, I mean, for most people who in practice, they know that you can explain everything. You can explain saying that this is only going to prolong life. It's not going to cure. There'll be some people who go for it. And then after 6 months, come back to you saying it's very expensive. Then what do you do?
Yeah.
That's a part of practice. There's nothing you can do about it.
Yeah, adding on to that, I think that is, you know, because no one, as a human being, I think as doctors, it's very difficult to tell a patient that we have nothing left we can do. And I think as a patient, you're just sort of grasping at every last thing and hoping for a miracle. So, and, you know, in answer to your question, why do they have such complicated, miserable names? There is a working group on behalf, which is formulated by the WHO. I read it a while ago because even we were wondering why do they have such names which you just can't remember. Sorry. There's some international working group formulated by the WHO for these sort of drugs, in which there's a prefix, suffix, etc., depending on how the drug has been made. All those have to be apparently put in the name. I don't exactly remember. It said there's a prefix, some subset, etc. What the antibody contains. All of that has to be in it, and that is how you land up with this complex name. And what Dr. Vidya said about patients falling in love with oncologists, I think that happens in pediatrics, because pediatrics has the joy of having, you know, once you treat 70% of them survive for the rest of their lives. So I think they probably love us. I will not comment on the adult side.
No, pediatrics, that happens. I've seen it happen.
Yeah, because we see them grow up going to school, college, and also because there's
much more involved.
Obviously, and there's a 70% survival with cancer. So that is why, you know, that is definitely there in pediatrics. So it probably works both ways.
There is a naming convention, which has, I think, just recently they have updated it. I just read an article a couple of days ago. So there's a naming convention there. But what's happening is these names are unpronounceable now. So I'm going to start talking about a brand name now, which is exactly, I mean, what WHO should not be wanting to happen.
The other thing is, whenever the patients are on these medications, you know, there is some program like buy one get one, or you know, buy two get five. I mean, what exactly are those things? Are they really ethical and, you know, scientific and permissible methods, or is some sort of a sales thing?
No, it goes through a third party. The company is never involved in this. It goes through a third party. It is for approved indications. And most of the support programs are for very good indications. Some people, the ones who make oral tablets, they give you a support saying that you spend this much and no more. Okay, particularly in breast cancer, there are 2-3 drugs like that. You spend this much and no more. Imatinib initially was supported by Max Foundation, free for people. So there are support programs, they work very well. The company is not involved, it's a third-party administrator, and I think they are able to give whatever help is feasible. For antibodies, I think it's probably it's a cost of manufacturing more. Nobody is giving this kind of support. They're giving for pertuzumab, but that's after 24 months. So pertuzumab will cost you about 30 lakhs by that time. So I discussed with many of these people. I said it's very traumatic to discontinue a working treatment because you don't have money. So best support is that which takes care of that. If somebody 3 or 4 months down the line person doesn't respond, that's okay. But suppose at 7 months you're spending 1 lakh a month and you're responding, then what do you do? Those oral medication programs take care of that. I have patients on 3 years and 4 years after they paid 1 year. One year. That is meaningful. Very difficult to, I can just imagine what people go through when they know that the response there and they can't spend. But programs work. I think they are good, and and I'm told they're doing across the world. Many of the multinationals supporting across the world. They work, they try to do something, and they have a very good system, and it always works. I've not had a single patient who's said that it doesn't work. They're very sincere about that. I think that's.
The other issue I had about the nomenclature is that it could be either an immunosuppressant or immune stimulant, and it will still end with the same 3 letters. So that's even more confusing for a lay person like me. So thank you everyone for joining. It was a.
So Vidya, can I just add MAB stands for monoclonal antibody. So it doesn't really tell you whether it's a stimulatory antibody or an inhibitory antibody. So that's why everything ends with MABs. They're all MABs. So.
Doesn't help ignoramus like me.
No, it doesn't help anybody.
Actually, the MABs have become known thanks to COVID now. Even the patients and everyone knows about MABs.
The cocktails,
That's the only thing that's happened. So thank you, Ravi Shankar, for putting this program, helping to put this program together, and thank you Avinash and Amita for spending your time, and thank you everyone for joining. And like Dr. Shenoy said, probably the recording will once the content is known, I think we will have a lot of viewers from postgraduates to watch the recordings across specialties. So we'll be taking a break next week for Tamil New Year's Day, and we'll be back on 21st with yet another episode of Marvelous Medicine. Thank you everyone for joining. Take care and stay safe.